All right, so we'll pick up with looking at the circulation involved in the kidney. So when you think of these structures, think of what is part of the blood supply, what is actually part of the kidney. So the glomerulus, is that part of the vascular system, or is that part of the renal system? What's inside the glomerulus? In a real simple way, what's inside the glomerulus? Blood. So it's part of the cardiovascular system. The glomerulus is a capillary. It's a modified capillary that's part of the cardiovascular system. So that's, you know, it's not specifically a kidney structure. I mean, it's found only in the kidney, but it is part of the cardiovascular system. It's a special capillary bed. And what's unique about the glomerulus? Yeah, it has two arterioles. It has an afferent arteriole and an efferent arteriole. And we can control the diameter. We can constrict or dilate those arterioles to regulate the pressure inside the glomerulus. And the more pressure I have in the glomerulus, the more filtration I'm going to have out of the glomerulus. Would you agree with that? Think of the garden hose leading to your sprinkler. If I turn up the hose, increase the pressure of fluid going into that sprinkler, I'm going to have a taller sprinkler, right? So more filtration, more loss of substance from the blood into the urine. Do we want to filter all of our fluids and electrolytes into the kidney and leave it there? No, we need to get it back. Okay, so filtration that we're going to talk about in the glomerulus, it's really important that we understand that it's a passive process and we need to get a lot of that stuff back that's filtered out. So that's the job of the peritubular capillaries. The peritubular capillaries and the vasa recta, their job is to take whatever's been filtered out of the blood, out of the glomerulus, and get it back to the blood. So the peritubular capillaries and the vasa recta are very closely connected to the nephron to allow substances to leave the nephron and go back to the blood. So the peritubular capillaries and the vasa recta are part of the cardiovascular system because they contain blood. So where do they connect? Where do they start? The peritubular capillaries arise from, and the vasa recta both arise from the efferent arteriole, And then they go back to the blood, eventually hooking up with the, do I have a picture in here somewhere? I do. To go back to our nephron picture, going up here. They go back to the blood. Here's my peritubular capillary shown in purple here. So they go back to the blood via the venous system, right? The cortical radiate vein, the arcuate vein, interlobar vein, and then back to the renal vein, right? So this is just, again, part of our cardiovascular system. So these are the peritubular capillaries. So if you don't know that, draw a picture. And where do we find the peritubular capillaries? Up around the distal and proximal convoluted tubules. And then the vasa recta, same kind of thing, arises from that efferent arteriole, but that goes around these long loops of Henle. And what type of nephron are these that have these long loops of Henle? Yeah, juxtamedullary nephrons. And recall that 15% of our nephrons are juxtamedullary, and these are important for making a concentrated urine. And animals that need a concentrated urine all the time because they don't have a lot of water in their environment, so they don't want to be peeing a lot of water, they want to hang on to it, they have more of these juxtamedullary nephrons to make a concentrated urine so they don't lose a lot of water through urine. Okay, so that's the vasa recta. So just keep in mind your structures and where they belong in the major body systems. Peritubular capillaries, vasa recta, part of the cardiovascular system, as well as the glomerulus. So these are blood vessels. So the glomerulus is filtering things out of the blood. The vasa recta and peritubular capillaries are reabsorbing things from the urine back to the blood. So if we look at the arterioles that feed the glomerulus, there's high resistance to flow. Those vessels are small and their diameter can be controlled. And we'll talk about that today. So we have high blood pressure heading from the renal artery of 95 millimeters of mercury, but because we have resistance within that afferent to efferent arteriole, we're basically squeezing both sides of our garden hose. So the area in between where I squeeze both ends is a lower pressure of only 8 millimeters of mercury, because that glomerulus is very delicate, very delicate. So if we don't have good control, or if we have chronically high blood pressure like we see in people with chronic hypertension, that does damage the kidneys over time. Okay, so having that high resistance protects the glomerulus from, a big increase in blood pressure happening with stress. We don't want that to act on the kidneys, so the afferent arteriole constricts to slow down the flow and decrease the pressure in the glomerulus. And we'll talk about that. So this juxtaglomerular apparatus, I gave you a handout today. Are there any extras of that handout? So there's an error in your PowerPoint that I want you to fix. It says the distal portion of the ascending, thank you, loop of Henle. That's not correct. It's actually the ascending portion of the distal convoluted tubule. So it's the ascending portion of the distal convoluted tubule. And a portion of the afferent arteriole. Sometimes efferent, but we're just going to look at the afferent. So there's special cells that make up the juxtaglomerular apparatus. There's 3 groups of cells that you need to know where they are and what their function is and how they affect blood pressure. So this is a very important regulator of blood pressure, and it's an intrinsic control of blood pressure, meaning it's within the kidney. The kidney can control blood pressure right within itself. It doesn't need outside influence. And I was talking to a relative over Thanksgiving who's in her 70s who said, yep, I'm going off my cholesterol medication and my blood pressure medication because I just don't like taking medications anymore. So I talked to my doctor, and we're dropping my cholesterol because my cholesterol's been good. And I'm like, okay, well, you're on medication, so that might be why your cholesterol is good. So, okay. So the doctor's dropping her down to 3 days a week. That's reasonable. Drop down to 3 days a week, check the cholesterol. If it stays down, that's a good plan. But then she wants to totally stop the blood pressure medication. And she said, well, I've lost weight, which is good. That's true. Weight does influence blood pressure. But in the 70s, we know that kidney function declines with age. That is a given fact. We lose the number of functional nephrons as we age. And that starts around 60, 65, and just continues. So we have to be careful with the elderly. They don't have good blood pressure control because their kidneys are not functioning as well. This juxtaglomerular apparatus is not doing the job quite as well. They're not filtering and reabsorbing appropriately, so they're at risk for electrolyte imbalances. And if we give them a drug, and we know that that drug is cleared by the kidneys, say it's ibuprofen, it's cleared by the kidneys, we give them that drug and we say you can give another dose 6 hours later. Well, in a person with declining kidney function, is it going to be out of their blood 6 hours later? No. And then we dose it again. We can end up giving people toxic levels of medication by not factoring in that they have declining kidney function. So we really have to look for side effects. You give someone hydrocodone, and you look at them 4 hours later when you can redose. If they still seem groggy and sleepy and kind of out of it, you don't want to just give them another dose of hydrocodone. You want to wait, or maybe try another medicine that isn't cleared by the kidney. Some medicines are cleared by the liver, such as Tylenol. So kind of alternating is a good approach for the elderly with declining kidney function. So I told this relative, I said, so you think you don't need this medication anymore, so that you mean your kidneys are getting better with age? Because we know that the kidneys are not. And she kind of laughed at that one. Well, I don't know, no answer to that one. And then the other one was, well, I feel good. I mean, my blood pressure was like only 145, and I feel good. And I said, and I know this person very well, so I was being kind of smart alecky. I said, oh, so blood pressure is no longer the silent killer either? It's only if you have symptoms that we should be concerned about blood pressure? So, I said, you'd have to show some evidence. Have your doctor, really provide some evidence that kidney function does not decline with age and that blood pressure is no longer the silent killer to really convince me that you should go off your blood pressure medication. Because, and you're going to hear that from your patients, yeah, I stopped taking insulin because my blood sugar was good. Well, it's terrible, and you're here for diabetic ketoacidosis because you stopped taking your, medication. Or I stopped taking my cholesterol medication, my blood pressure medication, because my pills ran out and I was feeling good, and now you're in for bypass surgery. So you have to talk to the patients and tell them these medications are working, and that's why we take them. You don't just stop taking them because you feel better. But again, it's good to have a goal to not be on too many medications, because we know here in the United States, our healthcare is driven by throwing pills at people rather than trying to alter lifestyles and have better diets, get more exercise, things like that. So it's trying to find that happy balance. All right, so if we look at the handout I gave you, there's a nice picture there. I'm going to pull it up on my computer because when I'm recording a lecture, I can't use the .cam. So for your lab exam, you have to know this structure, the Juxtaglomerular Apparatus, and it's made up of 3 different cells. And I would recommend, if you have a colored pencil, to color these cells so they really stand out to you. The first, yeah, there is a printing error, a formatting problem, and it's not on there, but it is on your PowerPoint. So just page ahead to your PowerPoint. It's figure 25.8 in your PowerPoint. Just page ahead a little bit. Right here. So color it on here if you don't have it on your diagram. So, and I'll use this one as long as it's here. But anyway, so you have these special cells of not the ascending loop of Henle, but the distal convoluted tubule. And I had to go back and forth between 4 different textbooks to figure out what it really is, and 3 of the 4 said distal convoluted tubule. This is the only one that said ascending loop of Henle, so I'm going to go with the majority. So anyway, these are what are called macula densa cells. And if you look at the table here, what are the job of the macula? Well, where are they found? They're found in the ascending limb of the distal convoluted tubule. They have chemoreceptors, so they detect chemicals in the urine, because this is part of the nephron, so there's urine in here. And what stimulates those chemoreceptors are high sodium chloride concentrations. So the faster sodium chloride is passing by these chemoreceptors, the more stimulation of those chemoreceptors. What? Oh, yeah, there's 2 tables. Make sure you're on the same side as me, on the front side. See, yeah, this is really bad formatting. What in the heck happened? Did it? Yeah, I don't know what happened with this formatting. Because it came from the same pile, and half the pile I handed out yesterday was correct. This half is bad. I wonder if they did it in 2 different batches. Anyway, so this is on Blackboard for you, so print out your own copy that looks better. But you can at least do highlighting on here. Okay, so it has these chemoreceptors, and what it does is when there's too much sodium chloride passing through, it releases 2 chemicals, ATP and adenosine. And those chemicals will cause constriction of the afferent arteriole, so it's going to slow blood flow going into that glomerulus. And if I slow the blood flow, that's going to decrease my net filtration pressure, so the net amount of fluid leaving the glomerulus, and the glomerular filtration rate. And that's going to give us more time to reabsorb those electrolytes back into the blood. We want to just slow that process of fluid entering the kidney. So that's what the macula densa cells' jobs are, is when they see too much sodium passing by, they're stimulated to release adenosine, and ATP, which causes constriction of this afferent arteriole. Now the afferent arteriole, when it has too much stretch in the walls, it has mechanoreceptors which are stimulated by increased stretch, so too much blood flowing in through here due to a high blood pressure, and that's why I have on the side here high blood pressure, high GFR, the two are linked. That's going to cause it to constrict reflexively. So it reflexively constricts, again reducing flow, reducing glomerular filtration rate. And why is all this important? To allow time for reabsorption of electrolytes. And the mesangial cells are in between here, shown in white. Those are the mesangial cells. So if you're looking back at the PowerPoint picture, they're shown in light blue here. So these are the granular cells on the outside of the afferent arteriole. These are the granular cells that cause constriction. Again, these are the macula densa cells in kind of purplish color. And then the light blue, kind of the mediator between these two cells, are the mesangial cells. And their job is just to communicate action potentials. So if action potentials fire here, those action potentials are transmitted to the smooth muscle cells of the afferent arteriole, and vice versa. So the job of these is just to relay information between these two important parts. So they have lots of gap junctions. And remember what gap junctions do? They're just openings for ions to flow, leading to action potentials. Where did we see gap junctions before? In the muscle cells. Which muscle cells had gap junctions? Cardiac and? Yeah, very good. Smooth muscle, single unit smooth muscle had gap junctions. Okay, so that's the function of the three different cells of the juxtaglomerular apparatus. So that would be a basic question I could ask you on the test. Which of the following make up the juxtaglomerular apparatus? And you should see mesangial, macula densa, and granular cells. And then I'll ask you, macula densa cells, what do they do with the high blood pressure? Secrete ATP and adenosine. What do the granular cells do? They reflexively constrict. Now, with a low blood pressure, we have a lot more controls in the body, a lot more negative feedback controls to control a falling blood pressure. So now we have too low of a blood pressure, so decreased stretch is going to do something different to those granular cells. Decreased stretch is going to stimulate those granular cells to secrete a hormone called renin. And renin starts this chain of events, chain of hormone reactions that we'll talk about in just a minute, but let's just leave it at that for right now. So the granular cells secrete renin. The macula densa cells, when those chemoreceptors are not stimulated by sodium chloride binding, that inhibits ATP production and adenosine, and that inhibition stimulates granular cells to secrete more renin. So we get more renin indirectly by the macula densa cells. So the macula densa cells are kind of nudging those granular cells to say, yeah, keep doing that. Keep secreting that renin. Okay, so the granular cells are stimulated to do it on their own because of decreased stretch, but the macula densa cells also encourage the granular cells. And then the mesangial cells, same thing as before. They're just relaying information between the two parts. But the effect of that is to dilate the afferent arteriole. So we're opening up that afferent arteriole to get more blood flowing through when we have a low blood pressure. So if we have someone with really low blood pressure, they have healthy kidneys, but they have too low of a glomerular filtration rate because of too low of a blood pressure over time, what would I look for? What's going to happen? What's a sign, an external sign? Like you did your case studies and you're looking at your patient, lab values. And if they have a low glomerular filtration rate because of low blood pressure, what would be a sign of that? Yes. What did you say? Right. No urine production. No urine production. Anuria, right? A-N-U-I-R-A. Wait, A-N-U-R-I-A. Not enough urine production is oliguria. Yeah. Yeah, less than 50 50 mils in 24 hours is anuria. The polyuria is more than, what is it, 2.5 liters or? Yeah. So in between there is the oliguria. Less than 400, 50 to 400. Yeah, yeah. Oliguria. Yeah. Less than 50. Yeah. Yep. Yep. Right. Yeah. We typically use a 24-hour period to see, but in surgery, you know, when some patient comes out of surgery, we look within, what is it, an hour? They have to produce a certain amount of urine within an hour just to make sure their kidneys are back after surgery. But anyway, so anuria. Okay, so other control. So these are intrinsic. The juxtaglomerular apparatus is an intrinsic control. But there's also extrinsic controls, because what happens is renin, when it's secreted not only to the blood within the kidney and acting on the kidney itself, but it also is secreted throughout the body because it's secreted to the blood. It's a hormone. So it goes to the blood that acts on the kidney, but also acts everywhere else. And what it does, on the bottom here, I have, this is a system-wide reaction. So renin acts in the blood, and in our blood is a protein called angiotensinogen. Doesn't do anything until renin acts as an enzyme and converts angiotensinogen to angiotensin 1. Angiotensin 1 now is floating around in our circulation, and as that blood flows through the pulmonary capillaries, cells within the lungs release this enzyme called angiotensin converting enzyme, which we can abbreviate as ACE. ACE converts angiotensin 1 to angiotensin 2. Angiotensin 2, there should be not an N in there. Angiotensin 2 is the hormone we want to help blood pressure. Angiotensin 2 has several different functions within the body. So we start with renin, and that helps get us to angiotensin 1, and then ACE helps us get to angiotensin 2. So what it's going to do, angiotensin 2 forms in the blood with the help of ACE. It acts on the blood vessels. And what does it do to the blood vessels? I've numbered these so you can correlate the number with the function. So what does it do to the blood vessels? Causes vasoconstriction. Acts on the adrenal cortex. What does that do? Promotes aldosterone release. Acts on the renal tubules. Increases sodium reabsorption. Another typo. Sodium reabsorption. Acts on the posterior pituitary to increase ADH production. Acts on the hypothalamus to activate our thirst center, and acts on the kidneys to cause the kidneys to make more angiotensin 2. So lots of functions of angiotensin 2, and all of these, if you look at these functions, those all fix a falling blood pressure, wouldn't it? Because if you look at the function, say, let's look at aldosterone. What is the function of aldosterone? It increases sodium reabsorption and potassium excretion. So if I reabsorb sodium back to the blood, water follows salt, right? So if I have more salt in my blood, I have more water in my blood. And what is that going to do to blood volume? Increase it, and which is going to go do what to blood pressure? Increase it, okay? If I look at ADH, what is the function of ADH? Acts on the collecting ducts, inserts aquaporins to increase water reabsorption. So now we're reabsorbing water back to our blood. That's going to increase blood volume. That's going to increase blood pressure. So this renin really sets off a chain of events that kicks in these other three hormones. Angiotensin 2, aldosterone, and ADH are all influenced by increased renin production. So that's why you have to know this summary here. And angiotensin 2, like we said, causes more aldosterone. So does it make sense when a person has high blood pressure that one of the groups of medications for blood pressure is an ACE inhibitor? If we inhibit ACE, what are we inhibiting? We're inhibiting angiotensin 2 production, which will also inhibit what other hormone? Aldosterone. That would be a good test question. If I inhibit ACE, I inhibit angiotensin 2, I inhibit aldosterone, and all those things that are meant to raise blood pressure are blocked. So therefore, my blood pressure stays down, which makes sense. Okay, if we look at other controls, so hormonal controls are example of extrinsic controls of blood pressure. They act outside the kidney. They're secreted outside the kidney, right? But then they can act on the kidney. I said that wrong. So hormonal controls are something that are released outside the kidney, but they act on the kidney to control blood pressure. So epinephrine and norepinephrine. The adrenal medulla secretes those hormones under sympathetic stimulation. So if I have fight or flight going on in the body, stress, that acts on the kidneys to raise blood pressure. So it acts on the blood vessels, causing vasoconstriction. So epinephrine, norepinephrine from the adrenal medulla causes vasoconstriction, and that's going to raise blood pressure. So is chronic stress hard on the kidneys? Definitely. So that's another, these are all examples of extrinsic controls. Anytime we have the nervous system stimulating the kidneys through epinephrine and norepinephrine, or these other hormones being released, those are all extrinsic controls. So intrinsic controls are something, again, that are happening within the kidney. So when these granular cells intrinsically constrict or dilate depending on the amount of stretch, that's an intrinsic control, right? Same thing with the macula densa. That's within the kidney itself, constricting that afferent or dilating the afferent arteriole. That's an intrinsic control. Okay, so we'll go back to the PowerPoint. So that's the juxtaglomerular apparatus. So we're going to talk more about the process of filtration. If we look at the glomerulus, we're going to kind of start at the top now, looking at the glomerulus. We're going to work our way all through the nephron and talk about the exchanges that take place between them. So if I look at the glomerulus is very leaky because it has these extra holes in the membrane, these pores between the simple squamous cells of the capillary, which are called fenestrations. So know that term, fenestration. So we see lots of fenestrations in the glomerulus because you want that exchange to take place. You want that filtration to take place. Do we want to see fenestrations in the capillaries serving the brain? Do we want the blood mixing with the nervous tissue fluids? No. We want to protect that nervous system from infectious material that might be in the blood. Chemicals, we don't want that entering the brain. Water-soluble chemicals, anyway, can't leave. But we know that lipid-soluble substances can. Carbon dioxide, oxygen can leave the capillaries and enter the brain tissue, right? And we know that alcohol can do that. But for the most part, the brain tissue is sealed off from the blood because it's called the blood-brain barrier. We have tight junctions between cells that make up the capillaries of the brain. We don't see that in the kidneys. We see lots of pores, lots of fenestrations to filter that fluid out. But we do see a little bit of a protective barrier, and this is the glomerular capsule. It's just an outer layer of the glomerulus that has these special foot processes, these special cells that do create a little bit of a barrier. So not everything that can enter through the pore actually leaves the glomerulus. And this basement membrane also has some sticky glycoprotein material that helps repel proteins. So it's slightly negatively charged here. So any negatively charged proteins that want to leave the glomerulus can't because of these foot processes and this basement membrane. So when we talk about filtration, we're not losing protein. We're not losing red blood cells, white blood cells, or platelets. Those are stuck in the glomerulus, and they're going to stay in the glomerulus. We don't want those things to enter the urine. And if they do, there's something wrong with this membrane here. This filtration membrane is damaged in some way. Like if someone has glomerular nephritis and it's inflamed, this membrane is inflamed, it becomes extra leaky. And you might see cloudy urine because of white blood cells in the urine. You might see protein in the urine. You might see red blood cells in the urine. So those are all something that we want to correct. Okay, so the kidneys are filtering our entire plasma 60 times a day. 60 times a day, your entire plasma passes through the kidney. So that filtrate, what's in the nephron, what enters the nephron, we call that filtrate. That's just whatever's in your plasma minus the proteins, right? And the red and white blood cells. So plasma doesn't contain red and white blood cells. That's why it's not mentioned here, but there's no proteins in it either. So of that, only less than 1% actually becomes urine and heads to the bladder to be excreted from the body. So all this plasma is going through the kidney, but most of it, 99% of it, is reabsorbed back to the blood. We don't want to lose that. So the three processes that you really need to know some details about are filtration, reabsorption, and secretion. And a real easy way to think of that is, I kind of drew a picture of this for my other class, is you just take, let's see, a shape. I want to insert a shape. I'll insert let's do this. Okay, I'm going to fill this shape. This is going to be red. And then I'm going to do another one. Control-C, Control-V to this. And I'm going to make this yellow. So what have I got here? I've got my blood is in red. So this is my, what vessels are in the kidney did we say that exchange can take place? What vessels might this be? What are the two vessels? What might these be? Okay, paratubular capillaries. What else? Vasa recta. And what else? It's part of the cardiovascular system. It's in the kidney. Glomerulus. All right, so that could be any of these, right? This red bar, this blood vessel. So the whole process of filtration starts with, I'll make a bigger arrow. Where's my bigger arrow? Okay. So going in this direction, that's filtration. Because we're going from the blood to the nephron. So what part of the nephron could this be? What's the first part? Bowman's capsule, right? Then we have the proximal convoluted tubule, then we have the loop of Henle, then we have the distal convoluted tubule, and then we have the collecting duct. So this first arrow is called, this process where we go from the blood to the urine, to the nephron, filtration. Filtration. And then if we talk about the process, because we don't want all that blood, if that's our whole plasma volume, 60 times a day, we don't want that to stay there. So we want that to go back to the blood. So what do we call that process of going from the nephron back to the blood? Reabsorption, tubular reabsorption. And then we might have some substances that need to be actively put into the nephron. They're not necessarily filtered, but they're added at the end of the nephron because they're in excess, like acid-base imbalances we talked about. What does our body want to get rid of if we have a high pH? If I have a high pH, what is a high pH? Is that basic or acidic if I have a high pH? If I have a high pH, that is basic. So what do I want to get rid of? What ion is basic? Bicarbonate ion. So I would want to secrete bicarbonate ion, actively secrete bicarbonate ion. So that is something that we would get rid of, put back into the urine because we want to get rid of it, right? So that is bicarbonate ion. And if I have a low pH, what would I want to actively get rid of? Hydrogen ion. Yep. So let's say I'm breaking down penicillin. I'm going to get rid of those metabolites, that excess waste product. That would be something that I would actively secrete into the urine. So this typically occurs in the lower part of the nephron, distal convoluted tubule collecting ducts. So know the direction that substances are moving. So again, labeling these arrows. This is filtration. Happens right in the beginning. We filter from the glomerulus to Bowman's capsule. Then throughout the collecting duct, so you could just label out here. You could put glomerulus, Bowman's capsule. That's where this occurs. And the movement from the urine back to the blood, that's called tubular reabsorption, and that occurs in the proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. The rest of the nephron, we have a chance to pull that stuff back to the blood. And then secretion, primarily secretion occurs in the distal convoluted tubule, going from the blood, actively secreting to the urine. Okay, so we're going to go into these in a little bit more detail now. So this is a nice diagram from your textbook showing the process. So filtration happens here, the glomerulus to Bowman's capsule. And that is a passive process. So a key point is to highlight the word passive. And it's based on pressure inside the glomerulus. And the primary pressure acting outward on the glomerulus is hydrostatic pressure. So capillary hydrostatic pressure in the glomerulus is what acts outward. That's the highest of these values because we have some proteins inside the glomerulus that are causing an osmotic pressure to suck fluid into the glomerulus. But is there any proteins out here in the Bowman's capsule? Did any proteins get filtered out here? They shouldn't have if my membrane is intact. So there is no capsular osmotic pressure to pull fluid out. So we have these three pressures acting on the glomerulus. So if I add them up, if I take everything acting out, subtract it from what's acting in, I end up with 10 millimeters of mercury. That's my net filtration pressure. We call that NFP. Now, can that change if I have high blood pressure? Would that change my filtration pressure? Yes. If I have less protein in my blood, what would that do? If I had less albumin in here, that would reduce this value, and what would that do to net filtration pressure? It would increase it also, because there's less suck into my glomerulus. There's more push out, less suck in, so that would increase my pressure, net filtration pressure. So the net filtration pressure is 10. Okay, so how much, so the NFP, we call it the NFP, and it's very much related to GFR, which is glomerular filtration rate. And this is something you're going to see on labs from your patients. We can measure this, glomerular filtration rate. So that is how much plasma is leaving the kidneys per minute. So in a healthy kidney, it's anywhere from 120 to 125 milliliters per minute. So the more leaky my glomerulus, the higher the glomerular filtration rate. And again, think of filtration like you're making macaroni and cheese, and you're, pouring that pot of boiled noodles into the colander, and that colander has fenestrations in it, and the plasma's coming out. That's filtration. So the more holes in your colander, the more fluid that's leaving. Okay, so we can control that GFR by those intrinsic and extrinsic controls. So what did we say are some intrinsic controls? The JGA, yeah, the Juxtaglomerular Apparatus. And what are some extrinsic controls we talked about? Hormones and, it's up here, so this endocrine is hormone, right? So hormone controls. And give me an example of nervous control. What? Epinephrine via sympathetic stimulation, right? Okay, so extrinsic controls, renin kicks off that hormonal response, right? So we talked about that. So that renin-angiotensin mechanism where we get renin, angiotensin 1, angiotensin 2, that's an extrinsic control because that's acting system-wide. So this is just a flow chart kind of showing all the different examples, but here's the intrinsic mechanisms. Here's the extrinsic. So we have, again, sympathetic stimulation. That's an example of nervous. We have the different hormones where we see ADH, angiotensin 2. Those are not all listed here, but aldosterone is listed. And then the internal, within the kidney itself, are those intrinsic mechanisms. So that's glomerular filtration. It's passive. The only thing that's driving movement of substances is what? Hydrostatic pressure. Yep, hydrostatic pressure in the glomerulus is the only thing moving stuff. So is that selective? If I'm glucose, do I have a choice to stay in the glomerulus or enter Bowman's capsule? No. The pressure is just pushing me out. So the glucose and all the water and the electrolytes that we need for metabolism, those are all being squeezed out of the glomerulus. It's just bulk flow, we call it, hydrostatic pressure. So it's passive, it's non-selective. Passive, non-selective is filtration. Tubular reabsorption now is selective. So we need to get those nutrients back. What are some organic nutrients? Glucose is one. What are the breakdown products of proteins? What do we call those? Amino acids. So those are some examples of organic nutrients that we need to get back to the blood. We don't want those headed for the bladder to be excreted. We want those back in the blood. So there's active and passive processes. Two routes by which we claim things back to the blood is transcellular and paracellular. Transcellular is going right through the middle of cells. So if I'm glucose, can I diffuse right through the middle of a cell? No, glucose is water soluble, right? So it can't diffuse right through. So it's out here in my proximal convoluted tubule, headed for the toilet, right? Headed for the bladder. We don't want to lose glucose. The body's very selfish when it comes to glucose. We're going to take that, put it back to the blood, and this is my peritubular capillary. So I need to actively transport glucose from the lumen to the blood. So I need protein transporters here, don't I? Protein channels we've talked about, facilitated diffusion. If I have sodium, same thing, active transport. I need sodium potassium pumps to get that out of here and get it into the cell to get to the peritubular capillary. So that's an active process that requires energy. So when you're talking about transcellular, that's active processes. I'm pointing to water here, this one, solutes. This is our sodium, glucose, all those things. So that's transcellular, requires active transport to happen, protein transporters. Paracellular, we do find that these junctions between the cuboidal cells that make up the proximal convoluted tubule and the loop of Henle, they're a little bit leaky. So some solutes can sneak between cells through what we call the paracellular route. So paracellular is a passive process that if I have higher concentration here, lesser concentration here, that's going to drive diffusion through. So it has to happen between cells, though, because we know solutes, a lot of them are water soluble, and they can't just go right across the membrane. They need active transport to do that. But water can sneak through because there's aquaporins, little holes for water in the membrane. So that can diffuse through by osmosis. And it can diffuse through the same way as the other solutes between cells, paracellular. So if I have a lot of glucose here, a lot of glucose was filtered out. I have diabetes and I have really high blood sugar, So my plasma is full of glucose, and it gets filtered out into Bowman's capsule and enters the proximal convoluted tubule. Is all that glucose going to be transported back to the blood if I have overload here? Well, some can go paracellular, but a lot of it is active, and if my protein carriers are maxed out, they're working hard and they're binding to molecules, but they can't transport anymore, what happens to the excess? You end up in the urine. Yep. So there's a transport maximum of proteins that can transport these water-soluble substances and put them back to the blood. So this is all reabsorption, heading back to that peritubular capillary. So sodium reabsorption, actively transported, or it passes through by diffusion through that paracellular route. Again, organic nutrients like glucose, secondary active transport, there's a transport maximum. When it's exceeded, that substance is excreted. So that's a classic example is a diabetic who has sugar in their urine. It's because their proteins, carriers, in that proximal convoluted tubule are maxed out. They exceeded the transport maximum for that substance. So water, like we said, is reabsorbed by osmosis and helped with these little aquaporins that are holes in the membrane of the tubules for water just to flow through. So highlight that word, aquaporins, so you know what those are. They're specific to the kidneys. And again, these can follow by diffusion through the paracellular route if it's a cation, because charged substances can't pass through a membrane, but it can pass between cells. So how would a fatty hormone like vitamin D, how would that get back to the blood? Diffusion through what route? Passive. Okay, so it can go right through cells. Transcellular, but that would be an example of passive diffusion through that because it can dissolve right through that fatty membrane because vitamin D is a fat-soluble hormone, right? Okay, so most of this reabsorption, what we just talked about, occurs in the proximal convoluted tubule. So 65% of sodium and water. Most of sodium and water leave the nephron and go back to the blood in the proximal convoluted tubule. All nutrients, when we talk about nutrients, we're talking about amino acids and glucose primarily. Ions, other ions, so we're talking about potassium, hydrogen, bicarbonate, small proteins that may have leaked out. The loop of Henle is more selective. The loop of Henle has a descending limb that can only reabsorb water, and the ascending limb can only absorb salt. And we'll talk about that in our next lecture, how that works. But for now, just know that it's selective, and it has specialized segments that the downward loop is for water, and the upward loop is only for salt, sodium, chloride, potassium. So when you get to the end of the nephron, the distal convoluted tubule in the collecting duct, that is under hormonal control. So if we're talking about reabsorption at the end of the nephron, that's when we have some issues going on in the body, that the body secretes some hormones that acts on those nephrons and selectively reabsorbs. So parathyroid hormone, remember that? Parathyroid hormone is something that stimulates osteoclast activity, that if our blood calcium is low, we break down bone to release calcium to the blood. Well, that's not going to do us any good if we filter out that calcium and pee it away. So parathyroid hormone also acts on the kidney distal convoluted tubule collecting duct to reabsorb that calcium and put it back into the blood because we don't want it to pee away. Water, we want to hang on to water when we have what type of blood pressure? Low blood pressure. So we're going to secrete ADH, which inserts aquaporins into the collecting duct, and we pull more water back to the blood. But alcohol, we know, blocks ADH. Alcohol in high amounts. You can have a beer with dinner, be okay. Maybe have one an hour or two later, it'll be okay. But if you have a beer before dinner, beer with dinner, 3-4 beers after dinner, pretty soon you're going to the bathroom quite often, right? And that's because your alcohol in high amounts blocks ADH. And if this is the anti-diuretic hormone, anti-pee hormone, and you block that, the response is you're going to pee. More fluid stays in the collecting duct and enters the bladder as urine. And if a person who is in this influence of alcohol, they're not peeing away the alcohol they're drinking, they're actually peeing away their plasma, because it's just turning off that ADH production and they're peeing away their plasma. So if you look at the urine of someone who's been under the influence of alcohol, it's almost clear water because it's just plasma, high amounts of plasma, high amounts of water. So how do people feel the next morning after peeing away and drinking? That's their only source of hydration, is more ADH blocking. Very thirsty, very dry, right? And that's some of the signs of hangover and headache are due to the dehydration that occurs with that, and the electrolyte loss. And then sodium is reabsorbed by aldosterone. Remember I said when you look at this hormone, if you read it backwards here is how I remember it, RET, retain sodium, helps you reabsorb sodium back to the blood. And water follows salt, so if I pull back sodium, water goes with it, and my blood pressure goes back up. And this is the other one that acts opposite. Remember ANP, atrial natriuretic peptide hormone? This is secreted by the cells of the atria in the heart. When they're stretched with high blood pressure, they secrete this hormone that acts across the body. And when it gets to the kidneys, I mean it's circulated throughout the body, when it acts on the kidneys, it blocks reabsorption of sodium. So that leaves sodium in the nephron, and water follows salt, so we pee away that excess fluid. That brings blood pressure down. So of all the hormones we've mentioned, ANP is really the only one that acts to decrease a high blood pressure. Aldosterone, ADH, angiotensin II, renin, those all act to raise a falling blood pressure because that's more dangerous to the body on a minute-to-minute basis. All right, aldosterone, like I said, promotes sodium reabsorption and potassium secretion. So we just get more protein channels in the membrane of the distal convoluted tubule and collecting duct. So the more channels I have, the greater the ability to move those ions. And we have that sodium-potassium pump. So sodium and potassium are moving in opposite directions. So if aldosterone encourages reabsorption of sodium, what is it doing to potassium? What's the opposite of reabsorption? Secretion, right? All right, everybody's starting to get that glazed over look, so we're going to take a break. All right, so we're going to take a little break from the notes now and check your understanding what we talked about so far. So, filtration, reabsorption, secretion, you tell me which one. So if I'm looking at glucose, passive transport of glucose out of the glomerulus, which process? Well, show me your cards. Okay. All right, so we're out of the glomerulus. So what process happens in the glomerulus of the three? Filtration. And it's passive movement of glucose. Passive. Which of these three is the only passive process? Filtration. So when you hear the word passive, the answer is filtration. And we're moving glucose out of the glomerulus, so it's out of the blood. Right? Glomerulus is blood. Peritubular capillaries is blood. Vasa recta is blood. Right? So if it's going back to the blood, that's reabsorption. If it's leaving the blood, that's filtration or secretion, depending where it's going, right? The only place where filtration occurs is the glomerulus. Secretion can occur anywhere in the nephron. Most of it occurs in the collecting duct and the distal convoluted tubule. Okay, so let's give you another one. I'm looking at glucose. 100% of glucose undergoes this process in the kidney. 100% of glucose undergoes this process in the kidney. Correct, very good. Number 2, reabsorption. Yeah, reabsorption. All of it has to be reabsorbed back. Okay? This is substances such as hydrogen ion, bicarbonate ion, things that are in excess undergo this process in the kidney. If I have excess something in the blood, what do I want to do with it? Get rid of it. Which of these three processes is getting rid of? Secretion, number 3. Good, good. All right. If I look at ADH, the influence of ADH does this to water, encourages this process for water, ADH. And think of what the word ADH means. Correct. The answer is number 2, water reabsorption. I want to reabsorb that water, put it back in the blood. I don't want to pee it away. So remember, reabsorption is putting it back in the blood. All right. I want, looking at atrial natriuretic peptide. This decreases this process. Decreases this process for sodium. Atrial natriuretic peptide decreases this process. So when is, show your answers, not everybody's showing their answers. Want to get a feel. Atrial natriuretic peptide decreases this process for sodium. Okay, I'm seeing a rainbow out there. So atrial natriuretic peptide is a hormone, right? So it acts at the end of the nephron, distal convoluted tubule collecting duct, and it decreases this process for sodium. When is atrial, what is ANP secreted? When blood pressure is high, because the atrial walls are stretched. So I want to get rid of this extra volume in my blood, right? So what do I want to do with sodium? Do I want to decrease secretion or decrease reabsorption? I want to decrease reabsorption, so the answer is number 2. I don't want to reabsorb sodium back to my blood and have water follow it. So I decrease the reabsorption of sodium, keep it in the nephron, let the water follow it, and pee that extra fluid away so I don't have a continuing high blood pressure. All right, aldosterone causes this to occur with sodium. Aldosterone causes this to occur with sodium. Remember when you write the word aldosterone, read it backwards. Read it backwards. So it wants me to retain sodium, and retaining sodium, which of those 3 means retain? Reabsorption. So number 2 is the correct answer for that. Aldosterone also causes me to do this with potassium. What do I want to do with potassium with aldosterone? Good. Secrete it. I want to secrete potassium. All right. This process is driven only by hydrostatic pressure. Only hydrostatic pressure drives this process. See, mostly number 1, filtration. Yep, filtration. It's just whatever pressure is in that glomerulus, fluid pressure. All right. This process, aquaporins, the presence of aquaporins increases this process. The presence of aquaporins increases this process. Aquaporins. The answer is number 2, reabsorption. We reabsorb water by inserting aquaporins into that nephron, and that causes water to flow out. That's what ADH does. ADH inserts aquaporins in the collecting duct. High blood pressure, yes, will increase filtration. Yep, yep. There goes my question. And I'm glad that you brought that up, because that would have been a good question. Let's see, another one. If I have a constriction in the afferent arteriole, it will decrease this process directly. Directly decrease this process if I have a constriction in the afferent arteriole. Directly. Correct. It would decrease filtration because I have less blood flowing into that glomerulus, less can filter out. Because remember, filtration is happening in the glomerulus, only there, right? Okay, so that's just a little review. Hopefully that helps you kind of sort things out a little bit better. So we'll continue then. So tubular secretion for these excess ions, things that we need to move that are no longer needed by the body. So organic acids, those are like those ketones, keto acids that might be produced during fasting or starvation, right, or diabetic ketoacidosis. Creatinine, that's a waste product from eating protein, right, protein sources, meat in particularly. It's a good source of creatine phosphate. So muscle contraction releases that. And then ammonium ion, that too is a result of eating protein. Potassium and hydrogen, variable sources of that. So that's when we want to get rid of this excess from the blood. So it's going to the nephron, headed to the bladder. So we want to get rid of just excesses, depending on what the needs are. And we can control our blood pH by either reabsorbing or secreting these ions. Again, if I have a low pH, which ion am I going to secrete of these two? I have a low pH, which one will I secrete? I will secrete hydrogen ion. If I have a high pH, I secrete bicarbonate ion. If I have a low pH, I'll reabsorb bicarbonate ion to soak up that excess H+. And that's how our body does that, you know, compensating. That's how the kidneys. Yep, all to increase that base to soak up that excess hydrogen ion. Okay, so if we look at our urine then, based on all these solutes that are present in the plasma, if we look at the plasma, we notice that it has a given osmolality that represents homeostasis. And the value of that osmolality is about 300 milliosmoles. And your lab book, I think, said 285 to 300. Does that sound right? So know that value for lab. But we're going to use 300 for our purposes. So that's where our plasma should be, looking at concentration of solutes. So if I have a high osmolality, you have more solutes than water in your plasma. So what does that mean? What condition could cause that? Dehydration. So vomiting, diarrhea, excess urination with diabetic ketoacidosis, that's all going to cause increased osmolality. So that's another good test question too. Diarrhea, vomiting, increased urination from diabetes, all would increase osmolality. And our kidneys, we're going to talk about next time, has what's called a countercurrent mechanism that helps to establish this ability of moving water and salt out of the nephron into the blood, into the vasa recta, using this countercurrent exchanger. So our osmolality can be as high as 1,200 milliosmoles down in the medulla. So this is how we create a concentrated urine. So if we go from the cortex, that's equivalent with plasma out here in the cortex. So when we look at like where the glomerulus is in Bowman's capsule, that osmolality is 300. But as we move inside the nephron now, if we look at the osmolality deep into the medulla, it becomes much more concentrated as we move into the medulla. So osmolality is highest in the cortex, and osmolality is lowest in the cortex and highest deep in the medulla. So this countercurrent multiplier involves the loop of Henle and the vasa recta. Those two structures make up our countercurrent multiplier. So it's just a special name for these two structures. So we talked about like the Juxtaglomerular Apparatus made up of those three cells. What makes up the countercurrent multiplier? It's the loop of Henle and the vasa recta. They're kind of they're superimposed over one another. And we talked about how the descending limb of the loop of Henle is permeable to water. So water can leave the descending limb and enter what? When it leaves the nephron, what do we call that? Which of the three processes? No, filtration only happens in the glomerulus. Only there. Reabsorption. So we're reabsorbing water back to the blood. So if I have this permeability to water, what's happening to my concentration as I move down that loop of Henle? It's increasing because I'm losing water. It's becoming more and more concentrated. So at the base of the loop of Henle, I'm at that maximum value of 1,200 milliosmoles on the descending limb. But now if you look at the ascending limb, that's impermeable to water, but it's permeable to salt. So as my salt is leaving the ascending limb, so if it's going up now, and I'm losing a bunch of salt, what does that do to osmolality as I go back up loop of Henle? It decreases. And it decreases to as low of a value of 100 milliosmoles inside that loop of Henle. So if I look at this diagram here, it's 300 in the glomerulus and in the proximal convoluted tubule, but as water leaves, it becomes more and more concentrated. And then as it goes back up and salt leaves, it becomes less concentrated. So when I get to this final, distal convoluted tubule, it's as low as 100 inside here, my osmolality. So the vasa recta is the other portion of this countercurrent multiplier that is going to maintain this gradient for water to move and solutes. So we'll talk about how that works. So if you look at the vasa recta, it can exchange both water and salt. So as water is leaving the descending limb of the loop of Henle, where is that going? It's being reabsorbed by the vasa recta. So water is being reabsorbed by the vasa recta, and then as salt is leaving the ascending limb, that's entering the vasa recta via reabsorption. So it's going from the nephron to the blood. So this is basically soaking up from the interstitial fluid, these excesses that are being dumped in the interstitial fluid from the loop of Henle. It's taking that excess solute or water and putting it back to the blood. So again, it's becoming concentrated down here at the base because the opposite of what's happening in the loop of Henle is occurring in the vasa recta. So when we come back, I want to really have you, before we go into hormonal control of the collecting duct and all that, I want to visit this topic at the beginning of our lecture on Thursday, and I'll have a worksheet where you're going to fill in some information to really understand this, because this is a really important concept, and it's definitely a little higher level to understand the exchange. So we'll stop here and we'll pick up on Thursday, starting with this so you're fresh, because this is kind of an end of the lecture. Everybody's mentally fatigued, because I want you to understand that.